Chapter 6, Communication and Physical Assessment of the Child. This is just portions of this chapter. You had assigned pages, so it's just those pages. So, communicating with parents. We want to first establish a good setting where it's conducive to communicating with them. Ensure that we have privacy and assure them of confidentiality. Except the exception to that is if we think they are in danger of being hurt or someone else is in danger of being hurt or has been hurt. And we can tell parents that everything is confidential unless we're worried about yours, your child, or someone's safety. Encourage the parent to talk, but we do want to direct what they're saying. So we let them do most of the talking while we direct by asking questions. Listen to what they're saying, being sensitive to their culture with things like eye contact, how close we're going to sit, if we're going to touch them or not, if they, are looking upset. So be culturally aware. Use silence, allow them to talk. Be empathetic. This is hard. Even having a child in the hospital when it's not a life-threatening thing, it's still very emotional, very difficult for most parents. And anticipatory guidance. What are they likely to need to know? How are we going to direct them? Avoid things that are going to make a communication block. Anything that sounds judgmental is going to make the parent stop talking. The word why is terrible for stopping communication. Why did you go to that hospital? It sounds very judgmental. It makes parents defensive. What caused you to do that is a better way to ask it. Or tell me about how you picked that hospital. Find a way to ask it without using the word why, and you will usually get much more information. And when we're giving parents information, consider information overload. They can't, there is a limit to how much we can all absorb, and when you put someone in a stressful situation, their ability to absorb information is going to be even less, smaller amounts that they'll be able to retain. So let's set up a lot of short teaching sessions rather than one long one. They are in the hospital with their child. We're going to have to make sure there's a place where that child is safe and can play. The room is often good, but somewhere like that too. Now, at Children's Hospital, do not use any copy machines on the patient care areas. The only copy machine you should ever use is the one in the library, and even then I would make sure somebody knows you're not copying any patient information. Sometimes the nurses will print something for you and give it to you. Look at it. If you need to jot down some notes without any names, do that and then put it in the shredding bin. Now that you have access to the computers, you shouldn't need the nurses to do anything like that. Do not take home any printed information. Just don't do it. If you do print something, take your notes off of it, again with no patient identifiers, and put it in the bin to be shredded. Every nurse's station has a bin underneath the counter that's for shredding. Communicating with children. We want to make sure that we communicate at their developmental level. So we shouldn't be using large words with a small child, and we shouldn't be condescending to a teenager. We need to be at their level. For children, we want to get down to their eye level so that we don't look big and scary and intimidating. We want to approach them gently and quietly. I would say start out making eye contact and then look away and then look back and see if they're looking at you, and kind of make it a little game, and then get a little closer and a little closer. So as playful as you can do it, and as slowly as the child needs. Always be truthful. If we're going to do something painful, we're going to tell them that it's going to be painful. We're not going to say it won't hurt if it does. We may not, depending on their age, we may not tell them till seconds before we do it, because we don't want that whole anticipatory thing where they're crying and experiencing all the anxiety of it, for an hour before it happens. So we're going to tell them just as much time as we need to, which for a younger child can be very little, but we're going to be truthful about whether it's going to hurt or not hurt, or what, if parents are going to be there or not be there. Be truthful. And whenever we can, we like to give the child choices. Now, they do not have a choice of whether they want an IV or not. So don't say, I'm going to start your IV, is that okay? Doesn't matter if it's okay. They need the IV. But they can choose what clothes they want to wear today. Or if they want a movie on or cartoons on, or if they want juice or milk. So give them choices that are real, but don't give them choices that they don't have. And here's a picture of, be at the child's level talking to the child. When we're talking with kids, we want to avoid analogies and metaphors. That's pretty high level cognitive functioning, to be able to take a story, a moral from a story, and apply it to myself. Or to be able to understand it's going to hurt as much as something else. Those are just quite hard, particularly for young children. They won't really grasp that. We want to make sure instructions are clear, that we're using short sentences with simple words that they will understand. Again, not talking down to teenagers though. Try and give instructions in a positive manner whenever possible. So rather than don't touch your IV, let's say, I need to put this wrap over your IV to keep it nice and clean. Let's not touch it so we keep it nice and clean and working well. And try and make it positive as opposed to negative as much as possible. Avoid really long sentences that kids are going to get lost in what you're saying and not understand you. Again, I'm talking about younger kids. Even with teenagers though, being simple and specific, you can do that without condescending. Avoid medical jargon that they aren't going to understand. A kid doesn't know what DC means. They don't know what an NG, or they may know an IV if they've been there any length of time, but we talk in a lot of acronyms. So avoid those. Think about what words they will know. And also think about what words are scary. If the word brings a scary picture to the child's mind, even if it's not something bad, they're going to be very against it now and fight us. So try and avoid words that could have a scary connotation. With older kids, we want to give them a chance to talk when the parents aren't there. And unfortunately, there is child abuse. And the child is not going to tell us, if the parent is present, that, yeah, well, Daddy hit me and that's when I fell and broke my arm or whatever happened. So those sort of questions, or just that sort of talk, needs to be when the parents aren't there. And sometimes the kids just need a chance to vent, to say, yeah, Mommy and Daddy are so upset and I feel like it's my fault and my siblings are mad at me. Sometimes just letting them talk, to vent when nobody's around, is helpful as well. Now, kids are really literal. We need to be careful about how we say things, because a young child, you tell them, I'm going to give you a little stick in the arm, they're picturing a stick in the arm. So try and think, does this word have another meaning that they're going to picture it instead of what I want them to picture. So we want to make sure our communication is developmentally appropriate. Infants only communicate non-verbally, so that's what we're going to do with them too. We're going to smile at them, we're going to make happy sounds. If something's painful is coming up, we're not going to do the smiling and the happy sounds. Usually it's a good idea to, not necessarily when we're giving information, but just in talking with the kid, talk one level above where they're at. So an infant who's not really making sounds yet, start with those ooh, ah, and see if we can get them doing those, and then go to the mama, mama, and once they get there, then, so we're always kind of going one step, but only one step ahead of where they're at, to encourage that development. Now, in early childhood, these kids are very egocentric. They only see things in relationship to themselves. Trying to tell them about somebody else's experience is meaningless. They can't put themselves in somebody else's shoes. So we're wasting our time trying to do that. So focus our communication on them, what they will feel, what they will see, what they are going to experience. Be consistent. If we're doing a painful procedure, don't smile at them. But if we're not doing a painful procedure, certainly we want to smile at them. Use words they'll know. Again, avoid that medical jargon or words that are just outside of their vocabulary. School-age kids, these kids are old enough to understand what's going on, and they really have a need to know what's going on. I think this age often we talk to the family and forget about the child. They want to know why they're getting the medicines they are, how long they're going to be in the hospital, what is likely to happen next. With adolescents, sometimes these guys are very adult in their thinking and their behavior and in their interactions with us, and then all of a sudden they'll act like a little child and cry, and that's just part of being adolescent, and we just sort of go with the flow as they flip-flop around. Here's that literal thinking. Katie has a half-brother. She's wondering where the top half is. Or playing music in a different key. Why do you have a key for a piano? Okay. Play is the work of a child, and we need to incorporate play whenever we can into our assessments and into our care. For infants, we want things that appeal to their senses, things that they can pat, that have textures to them, colors and sounds. Infants love mirrors, and they have a lot of different play gyms that you can put over the infant in the crib with different things to touch and different sounds and things. Older infants, things like peekaboo, they love that, games like that, and you can use that as part of your assessment too. Small children, so a little bit older, we can do things like which hand. Let them pick which hand. As they get a little bigger, let's use play in our assessment. Can you jump? I'm jumping. Can you jump with me? Can you stand on one foot? Things that they should be able to do at their developmental level, kind of let's play a game and see if they can. Now, play is important for a lot of reasons for a child. It relieves stress. That's how they're going to relieve their stress of being in the hospitalization, being in the hospital by playing. Lowering the child's stress is going to lower the family stress, and everybody's just going to do better all around. It also is a good distractor for pain. Those non-pharmacologic pain measures that we want to incorporate into our patient's plan of care, for kids, that's going to be play. So find out what play they like, and let's encourage that, whether it be drawing or video games. It's also a good barometer of how ill they are. When a kid's really sick, they're too sick to play, and when they start playing again, that's a really good sign that they're starting to improve. And that's where I'll stop.